Well, thank you for coming, everybody. I'm Kerry. I work in the pharmacy here at the hospital, and I have a unique position as the medication history technician. And what is my job? I review all the home medications on file from the patient's last visit, if possible, before I go to see them. And then when I go to the floors, I check the patient's chart to see if the medication list was sent in by the family or a care center or hospice or any other providers who would be administering medication to the patient. And then I take everything I've collected and I go in and speak to the patient or to their family member if the patient can't speak to me, and try to come up with the best information I can for what prescriptions they take and how they take them. And a lot of patients often don't take their medications the way they're written, they take them the way they take them. So that way I can let everybody know this is what they're doing. And I also ask them about nicotine, alcohol, and recreational drug abuse, or use, sorry. They often bring me these, 2 or 3 big bags of them.
But they don't look that nice, right, Kerry?
They never look that nice, no. They're often very dirty, and some of them are from the year 2000, and they still saved certain pills just in case anything might happen. So I look through those, and then this is when I can have the pharmacist go talk to them upon their discharge and say, okay, all of these medications are expired and you're no longer taking them, so we can dispose of them for you. And that way they don't go home with a bunch of expired medications. Oh, I interrupted myself, I'm sorry. After I talk to the patients, I get the name of their physician and the name of their pharmacy. I first call the local pharmacies to verify their medications and the prescription the way it's written. Sometimes I have to call mail order pharmacies such as Express Scripts or certain place in Utah does a lot of patients' prescriptions up here. And once I get that information, sometimes there's still a conflict of information. So I will call their primary physician's office or like their cardiologist's office, whoever has written the prescriptions, and get a correct list from this person to put them together. So that way the hospitalist and everyone here knows that this is what they're supposed to be taking, and then when I go talk to the patient again, they say, oh, I quit taking that, or oh, I don't take that anymore. Oh, I take those 2 at night. So that way we can get a better idea of how they're treating themselves, so we can figure out if the way they're taking their medication is part of what's making them end up in the hospital. These were a bunch of bottles that I got, and they were full. And the bags also. That's how many drugs were in the bottles. After we had to count them and identify them and put them in there. And sometimes they don't come in bottles at all, so they look like that. And then with all the information that I've gathered from the many sources that I contact, I enter their medications into the chart, and that way the hospitalists, the nurses, and the people who have access to that information are aware of the medications and substances in the patient's system. And then I complete each one with a phone call back to the nurse and to the hospitalist to let them know, this is complete, you can review it now. And then I know that the nurses have to check off that, how do you guys do that? You have to check off that the home meds are done?
Just take it off the work list.
Okay, yeah, so that way you guys can do that so it stops duplicating itself. And I'm often a detective. Patients will often tell me things they don't tell the nurses. They also tell the nurses things they don't tell me. We talk to each other after both of us have spoken to the patient to get the rest of the story. Patients don't take their medications yet tell me they do, or they take too much of their medications and tell me they don't. And patients often keep every prescription they have ever been written, which is true from all the bottles that you saw in the picture. These are the most commonly hoarded medications that I found that people will keep no matter how old they are, which is your painkillers like codeine, fentanyl, morphine, hydrocodone and oxycodone, depressants such as Valium, Xanax, and Ambien, and then stimulants like Adderall, Dexedrine, methylphenidate, things like that. They'll keep those even though they're not taking them anymore, I guess just in case, but I'm sure they all have their own reasons why they're keeping them. And the most common medication errors that I find is that when the patients bring in prescription bottles or pill minders that are filled with medications, these are medications the patients are no longer taking. And the second most common error I find is that patients do not take their medication as directed. And an example of that is that a patient is written a prescription for their blood sugar that should be taken 3 times a day, and the patient takes all 3 doses in the morning or at bedtime. instead of having it spaced out every 8 hours, which is how the doctor intended them to take it. Once again, multiple bottles from multiple providers with the same medications. So they have 2 doctors who are writing them their Coumadin, or their high blood pressure medication, or their diabetes medication, or things that they should be only seeing one provider for. And that gives me the opportunity to talk to the pharmacist, so the pharmacist can do a consultation and talk to them about, how are you taking these, where are you getting these from, things like that, so that they can try to figure out a better game plan with case management and the hospitalist and the nurse when they go to discharge the patient, so that this doesn't happen again. Some of the most unusual things I've been told, I once was told by a patient's primary caregiver, which was a family member, that he decided to no longer give his relative his blood pressure medication because he didn't need it. His blood pressure had been good, so he just stopped giving it to him. And another question I asked of a patient was, do you use any recreational drugs? And the response I got was just marijuana and meth. Just. The just is very important there. And then, of course, I can't react to anything they say me. So I'm like, okay. And then I said, how long have you been using these substances? And he said, about 20 years. And the first thought I had is like, how have you not died? But that's his thing. And then this question makes me a little bit sad, because the patients will have diabetes or hypertension, and they tell me they only take their medication when they start to feel bad because they can't afford it. And a lot of patients tell me, I can't take that medication that often because it's too expensive. So instead of taking it once or twice a day, they'll take it once every other day. And then they end up with, an acute occurrence and end up back in the hospital. They're upstairs, they get everything regulated again, and then they go home, and however long this little plan of theirs works out, they're not in the hospital, but then they get sick again and end up right back in the hospital because they can't afford their medications. Doing what I do, which is my technical title is a medication history technician. And I put reconciliation in there because that's what the nurses refer to as a medication reconciliation. It allows them to no longer be burdened with the time-consuming detective work often involved in lengthy medication history data collection. This allows the nurses more valuable time for patient care and the other 10 zillion things that all of our nurses do. And we can work together as a team to obtain the most current and accurate data that will help the patients receive the best care we can offer. Because say I talk to the patient, and then Val talks to the patient, and then say you go in for a dietary and you talk to them and they tell you something else, then you can tell the nurse what they told you, I can tell the nurse, and then we can come up with more information so that helps everyone figure out the puzzle as to why they're here every month. And this is a blank document. John S. Smith is not a real patient, but this is my document that I use to go talk to the patients. The first thing I list is their name, their date of birth, and their room number, and I confirm with the patient if they have allergies or not. And he takes lisinopril, 10 milligrams in the morning, hydrochlorothiazide, zolpidem, multivitamin, and I continued it to the next page. And he also takes Lantus and metformin. And when I ask him about smoking, drinking, or recreational drugs, 2 packs a day for over 20 years. He drinks a 12-pack of beer and 6 to 10 shots of tequila a day. That is a real thing. Honest, that was a real thing. I won't say who, but that was a real thing. And then smokes marijuana 3 to 4 times a week. And since marijuana use has become more prevalent in our area, I ask all the patients who smoke marijuana if they get it from a dispensary or if they get it from, their buddy down the road. Because at least we know if they get it from a dispensary, it's marijuana. But if they're getting it from, the dude down the road, they could be getting spice or, different strands of, weeds and alfalfa and Lord knows what else. But at least we know if it comes from a dispensary, it's 99% certain that that's what it is. So that way you don't have to worry about them having poisoned themselves. And that was all those drugs in the esterilizer after I nuked them. Does anyone have any questions?
So what has been which group of patients are probably your most challenging patients, to get information from?
The most challenging, believe it or not, are people who are between 30 and 40.
Okay.
I don't know, I don't think they wanna talk about what they're doing and how they're doing it. And I've seen often that a lot of patients who are diabetic in that age bracket, they don't treat their diabetes. They won't take their insulin, they won't check their blood sugar, they won't take their metformin or glipizide or any of the things that they're supposed to be taking, and they end up here over and over and over again. And a lot of patients get uncomfortable when I ask them about, if they smoke or drink or use recreational drugs. And I can see that little shift in them, and I just tell them, I was like, I ask everybody this, whether they're 10 years old or 90 years old. And then I would just say, just whatever you tell me is between you and I. We just need to know what's in your system so that we know how to treat you and we know what to look for. Anyone else?
Do you think that how about the honesty of the patients most of the time? Do you think they're giving you all the accurate, correct information?
Most of the time, yes. Because when I come in there to talk to them, I'll pull the chair up next to their bed and I'll sit down next to them and I'll say, so how are you doing? How are you feeling? Things like that. And then I'll explain to them who I am and why I'm there. And I think that they get to relax a little bit because they know I'm not a nurse or a doctor or, for some reason they're kind of, scared to tell the nurses certain things, which I don't know why. And then I can just sit with them for a few minutes and chit chat, and then they'll open up and say what's true, what's not. But sometimes they don't. I'll go out and tell the nurse that, he drinks this much a day and he denies any recreational drug use. And she's like, he told me he smokes pot 6 times a week. I'm like, well, now we know the whole story.
Right.
Yes, ma'am.
Isn't there a way for pharmacies and physicians to see if the patients are already getting a prescription from somewhere else, or is that just narcotics, or am I just imagining things?
The DEA website will tell you in the state of Wyoming where they have filled prescriptions for controlled substances, which is like your Xanax, your pain medication, your Adderall, things like that. But unfortunately, it's not all connected to all the states yet. Because sometimes patients will go see a doctor in Utah, fill their prescription in Utah, then they'll see a doctor here, fill their prescription here, then they'll go to Colorado, then they'll go to Nebraska, then they'll go here. So they'll have prescriptions all the way around the state, but the only one we can really find is Wyoming.
Okay. I never thought of them going to other doctors for Coumadin. I thought of them,
Well, the only
doctor shopping for
The instance
other
that
things,
came
but-
from was from when a patient was being treated here and being treated at the University of Utah. And they got conflicting prescriptions. So we figured out that problem here and got them on the right course.
So one of the cool things that I haven't had a chance to look at it because we just rolled yesterday, but one of the cool things that I can't believe it wasn't on the pharmacist profile, but the physicians had access to it, but I bet they didn't know they had access to it, is there is a service, interestingly enough, that we pay for, that is it comes from insurance data. So if a patient filled any prescription with their insurance, not if they paid cash, it pops up on this, and I just forgot what it's called, SureScripts. And we just got informatics to add that tab to the pharmacist area, so we can at least see what's been filled by insurance within the past, I don't know how long it lasts. I think it shows up to a year's worth of data. So Kerry and I were gonna go through that this next week and see if we couldn't data mine that a little bit, because they filled it. So that at least cuts out a phone call to the pharmacy. Now, they could say, nope, I'm taking Coumadin, and you're like, hey, it's not on the SureScripts thing. Well, they could have paid cash. That's the bummer.
Yeah.
Because the database comes from insurance submissions, not from pharmacies.
That's interesting.
Yeah, it's somewhat helpful, but you have to know the source of the information so that you don't step in a landmine. Yeah.
Yeah, that's a really helpful thing, because often when I've called, if I have to call, say, Blue Cross Blue Shield, and then I have to call Express Scripts, Express Scripts can tell me all the prescriptions that patient filled everywhere.
Yeah.
Because they have access to that, because they're mailing the prescriptions out from their mail order pharmacy. And that's really a time saver when they have that, because then you know everywhere they went, what they got, who wrote it for them. Because I write down the provider who wrote the prescriptions too, because why are you seeing 4 different doctors one in Rock Springs, one in Green River, one in Evanston, and one in, say, Laramie? Like, why are you going to 4 different doctors? And then a lot of the pharmacies around here, I know for sure, they won't allow a patient to pay cash for a controlled substance prescription. unless they have no insurance, of course. But if they have insurance, they have to run it through the insurance, and sure enough, that little ding, this person got this medication 2 days ago at Walgreens in Evanston, because that way we can tell them, no, you can't fill it. And we would often write at the top of the prescriptions, RTS, which is refill too soon, and then the date, and then they'd go to the next pharmacy and that corner was ripped off.
Oh.
So then they would call wherever they had just come from to find out what it was, and then they wouldn't fill it either. Because we all got to the point where when I worked retail, we could tell each other's handwriting.
How about?
So they knew that I wrote this or something like that. And when, back in the day, when our ER prescriptions were the 4 squares, it would say 1 of 1, or 1 of 3, 2 of 3, 3 of 3. It would be an antibiotic, a steroid, and a painkiller. Well, they would bring in the little corner for 3 of 3 and not get the other ones, and the ER doctors finally said if they don't bring it in its entirety, they can't fill it.
Right. So, to what extent do you work with a care transition nurse to kind of talk to her about what she's going to assess when she sees the patient in the home, or that
Not
kind of
as
stuff?
much as I'd like to, but I can do that, because I did talk to Greer a lot, especially when I had people who were very non-compliant. I would go in with my little list and go over the meds with her and say, they haven't taken this, or this. They don't use this the way they're supposed to. And just, the different things that I found out, so that when she went to go visit them, she would have more information that would be able to provide them with more adequate care. And she knew to follow up and things like that, and make sure they're taking their inhalers and their diabetes medication, their hypertension, their cholesterol, the most important things that, make them end up in here, and then she could have a better base of what she was talking to them about.
It'd be interesting, I don't know if we can even get the data to see to what extent this alone is leading to decreased readmissions.
Yeah, well, I know that Cal's working on it. She's working on the readmission thing and she's trying to make it where when I put in that I found a patient error, I can say what it is. Because right now my data is all collected on a spreadsheet, and it's just a day by day. I did this many reconciliations. I did, it took me this much time, and these are the errors I found. And then there's another column where I can have pharmacist counsel, where the pharmacists go talk to the patients. And right now it's just numbers. But she's going to try to make it so when I put in, say, 5, it gives me a slot that says 5 names, and I can put in their names and which medications they were. So that way, when the nurses pull things up upstairs, you guys can see what the errors were too, instead of just knowing that I saw 5 or 9 or 6. My biggest amount of people I saw ever was 16 in one day, so far. But sometimes I don't have any, and then sometimes I'll have like 1 every hour. I told Dr. Rosamund the other day he was cut off from admitting people. Because I was running from med surg to ICU to ER back and forth. I'm like, stop it!
How is do you feel like the ED staff is utilizing you when they know they have a
Yes.
admit? Okay.
Yeah, because either Steph Molina will call me, Kim's real good about calling me, and so is Desi and Joanna.
Good.
Or I'll see that they're pending admin on the board, and I'll be like, so how soon before they go upstairs? And they're like, oh, they're already upstairs. Or, oh, it's going to be a while. So I'll go talk to them, like especially if it's like 4 o'clock and I'm getting ready to leave. I will go talk to the patients in the emergency room, do their complete med rec, and I can't put it in the chart yet because they're not admitted. So I will make a photocopy of what I did and give it to the nurse who's getting that patient. So that way they know the information's accurate and it's verified, and then they can just enter it into the computer. Because I'll list the name of the person I talked to at the pharmacy, which pharmacy, who's their primary care, and verify all the meds. And there's med lists that come up from downstairs, but they don't cross over from T-Systems to QuadraMed. But they're still in the chart, so that gives me another starting point.
That's good.
Anyone else? Yes, sir.
So it's always heartbreaking to hear when people can't afford the medications. Has that prompted a lot of conversations of, alternate therapies, or finding these people the insurance, or finding because there are certain programs out there that can kind of help patients pay for medication?
There are. I can't discuss that with them because it's outside of my scope of practice, but that's when I can go talk to case management and tell them they can't afford this medication, and I could let, what's her name? Who took over for Greer?
Patty.
Patty, yes, and I can tell Patty. And I know that they're working on getting which program is it, Renee, that they're working on right now? The med donation?
Oh, the med donation program.
Yeah, the med donation program where you can take in your unused medications, and I think right now that you can drop them off at Dr. Donaldson's office, and they go to Cheyenne to be checked and make sure that expired, not tampered with, and then you have patients who need that service, they do paperwork to qualify for it, and then there's no charge on the medications for the patients, but the providing pharmacy can charge up to $10 because the shipping and the handling and the packaging and all that stuff. And that was really successful at another pharmacy that I worked at, but unfortunately, excuse me, it closed. But I'm hoping that when they reopen, because they're supposed to reopen, I'm hoping that they start doing that too, because there's also the 340B program, which is similar. Would you say it was similar?
Yeah, it's pretty similar.
It's similar, and that's
Except for
just,
it's new drug.
yeah, it's new drugs that they get, and they don't have to pay the astronomical copays. It's based on a sliding scale according to their income.
We're hoping that one starts again with the Bear River Community Health Centers opening up over here. I don't know if that's what they're gonna call it.
Yeah,
That's
but that's what we're hoping, is that those two will open, because at that little pharmacy, we had a lot of patients that they didn't always get their care from our providers, but they would always get their prescriptions from us because they could afford them and they could qualify for those two programs.
Does it include insulin? Both of those programs?
It does.
Yeah, that was one of the biggest things, is we had to get insulin.
And it's crazy how cheap it is. It's crazy how cheap it is through that program. Yeah, it's crazy. And 340B is a federal program through Medicaid where they, basically what they did is they strong-armed the manufacturers and said, you will give us cheaper drugs for these level of patients. So I remember talking to Carla, the PIC over there. So where I spend, I don't know, it's like $200 for a vial of Lantus, she was spending 18 cents for it.
Oh my God.
Wow.
Yeah, and then we would charge the patient $2.
Yeah, yeah, it was huge. It was a huge difference.
Yeah, and we didn't take advantage of the fact that we only paid 18 cents for it. If it was 18 cents, we'd charge them $2, because I think that's what they decided on as the minimum cost,
Right.
was $2.
Yeah. Which is awesome.
Yeah.
And so if they get up and running over there, we do need to acquaint ourselves with the rules of how that works, because it's actually complex enough that if our providers write a script here, you actually can't fill it over there under the 340B program. You can fill it as a normal prescription, but you can't fill it as 340B. So usually how it's set up, and it really depends on how it's set up, but as I remember with Sweetwater, in order to get access to that 340B, you did have to see one of those providers. So not a problem. Say we're discharging somebody, let's call that provider and say, can we make an appointment with you later today or tomorrow? And then we can get that prescription written
By that
properly,
provider.
right? Does that make sense? So we would definitely have to think through the process to accommodate them being able to do that. But I think one of the mistakes that got sent out about that last pharmacy was somebody somewhere got it into their head that pharmacy could give out free drug, which is never the case.
Never, ever.
Never the case. That is never the
No.
case.
I
anywhere.
was told you would fill this for free.
Yeah.
Nope, we
And so
don't do that.
That made it really difficult for the patients to understand that there is paperwork, and that's unfortunately one of the burdens we put on our poor is.
Code blue.
Hasta la vista. We'll talk later.
Bye.
214.
214.
So, you know what? I want you to go in the pharmacy and grab whichever pharmacist and go with them right now.
Yep, got it.
All right, the end.
Hey, thank you.